Lower respiratory tract infections are a significant health concern, often beginning when pathogens colonize the upper respiratory tract. Once these pathogens reach high enough concentrations, they can enter the lungs, typically through aspiration of oropharyngeal secretions. Our bodies have natural defense mechanisms like ciliary function to prevent this, but when these defenses are compromised, such as by chronic inflammation from cigarette smoking, the risk of infection increases. In this video, we'll explore how these infections develop, the different types, and the ways they impact our health. Let's start by looking at how microbes find their way into the lower respiratory tract. While aspiration is the most common route for microbes to reach the lungs, there are other, less frequent pathways. Microbes can also enter the lungs via the bloodstream from other infected areas in the body, or by inhaling aerosolized particles containing infectious agents. The most common lower respiratory tract infections include pneumonia, bronchitis, and bronchiolitis. Each of these has unique causes and risk factors, but all share the potential to significantly impact respiratory health. Next, we'll focus on pneumonia, one of the most prevalent and serious lower respiratory infections. Pneumonia is characterized by inflammation of the lung tissue, often leading to consolidation, a condition where the air spaces are filled with fluid or pus. There are 5 main classifications of pneumonia: community-acquired, aspiration, hospital-acquired, ventilator-associated, and healthcare-associated. Community-acquired pneumonia occurs in patients who have not recently been in health care facilities, while aspiration pneumonia results from inhaling oropharyngeal or gastrointestinal contents. Understanding these categories helps guide appropriate treatment and prevention strategies. Hospital-acquired pneumonia, HAP, is defined as pneumonia that develops 48 hours or more after hospital admission. Ventilator-associated pneumonia, VAP, requires the patient to have been on endotracheal intubation for at least 48 to 72 hours before the onset. Healthcare-associated pneumonia, HCAP, is diagnosed in patients with recent hospitalizations, residents in long-term care, or recent exposure to healthcare interventions like IV antibiotics or hemodialysis. These distinctions are crucial for identifying risk factors and tailoring treatment. Pneumonia develops when microbial pathogens proliferate at the alveolar level, triggering the body's immune response. Microorganisms can reach the lower respiratory tract through inhalation of aerosolized particles, entry via the bloodstream, or aspiration of oropharyngeal contents. The interplay between pathogen invasion and the host's immune defenses determines whether an infection will progress to clinical pneumonia. Let's look at how viral infections can set the stage for secondary bacterial pneumonia. Viral lung infections can impair the lung's ability to clear bacteria by affecting alveolar macrophage function and mucociliary clearance. This creates an environment where secondary bacterial pneumonia can develop. Clinical pneumonia becomes apparent only when the capacity of alveolar macrophages to ingest or kill microorganisms is overwhelmed. This highlights the importance of a robust immune system in preventing severe infections. Certain individuals are at higher risk for developing pneumonia, including those with compromised immune systems, chronic lung diseases, or recent exposure to healthcare environments. Lifestyle factors, such as smoking, also increase susceptibility by damaging the respiratory tract's natural defenses. Recognizing these risk factors is key to early intervention and prevention. Pneumonia presents with a variety of clinical symptoms, including cough, fever, shortness of breath, and chest pain. The severity and combination of these symptoms can vary depending on the type of pneumonia and the patient's overall health. Recognizing these signs early allows for prompt diagnosis and treatment, improving outcomes for patients. Diagnosing pneumonia involves a combination of clinical assessment and diagnostic tools. Physicians look for characteristic symptoms and may use imaging studies, such as chest X-rays, to confirm the presence of lung consolidation. Laboratory tests can help identify the causative organism, guiding targeted therapy. Early and accurate diagnosis is essential for effective management. Primary objectives in treating pneumonia are to eradicate the offending organism and achieve complete clinical cure. Supportive care, such as oxygen therapy or mechanical ventilation in severe cases, and fluid resuscitation, are important components of treatment. The approach is tailored to the severity of the illness and the patient's underlying health status. Supportive therapies for pneumonia include the use of bronchodilators, such as albuterol, when bronchospasm is present, and chest physiotherapy with postural drainage if secretions are retained. Adequate hydration, optimal nutritional support, and fever control are also important. These measures help improve patient comfort and recovery. Community-acquired pneumonia, CAP, pharmacologic therapy is based on the severity of the illness and recent antibiotic use. Mild cases in ambulatory patients without recent antibiotic exposure are treated with macrolides like clarithromycin or azithromycin, or doxycycline. If there has been recent antibiotic use, amoxicillin or amoxicillin clavulanate may be added. Hospitalized patients with severe pneumonia require intravenous antibiotics and close monitoring. Non-pharmacologic management of CAP includes bed rest, adequate hydration, and frequent monitoring of vital signs. Oxygen therapy may be administered via nasal prongs or face mask to maintain adequate oxygenation. Attention to fluid and nutritional replacements is also essential, especially in severe cases. These supportive measures complement pharmacologic therapy and promote recovery. First-line antibiotics for hospitalized patients with severe CAP include ceftriaxone or benzoyl penicillin, often combined with a macrolide like azithromycin or clarithromycin. In cases of beta-lactam allergy, respiratory fluoroquinolones such as moxifloxacin or levofloxacin may be used, but these are reserved for situations where other options are unsuitable due to their role in tuberculosis treatment. Management of CAP involves both non-pharmacologic and pharmacologic strategies. Non-pharmacologic measures include bed rest and hydration, while pharmacologic therapy is tailored to the patient's history and severity of illness. The choice of antibiotics is influenced by recent antibiotic use and the presence of comorbidities, ensuring effective and safe treatment. Healthcare-associated, hospital-acquired and ventilator-associated pneumonia, empirical antibiotic therapy is broad-spectrum to cover resistant organisms. Once culture and susceptibility results are available, therapy should be narrowed to target the identified pathogens. The timing of onset and risk factors for multidrug-resistant organisms are key considerations in antibiotic selection. Early onset pneumonia, occurring within 5 days of admission and without risk factors for multidrug-resistant organisms, is typically caused by pathogens like S. pneumoniae and H. influenzae. Recommended therapies include third-generation cephalosporins, respiratory fluoroquinolones, or ampicillin/sulbactam. Late-onset pneumonia or cases with risk factors require broader coverage for organisms like P. aeruginosa and MRSA. Late-onset pneumonia in cases with risk factors for multidrug-resistant organisms require empirical therapy that covers a wider range of pathogens. Antibiotics such as cefepime, ceftazidime, imipenem, meropenem, piperacillin/tazobactam, and aminoglycosides are commonly used. If MRSA is suspected, vancomycin or linezolid should be added to the regimen. Once microbiologic results are available, it's important to de-escalate to narrow-spectrum antibiotics and switch to oral regimens when appropriate. This approach minimizes the risk of antibiotic resistance and adverse effects. Empiric regimens are always subject to modification based on clinical response and laboratory findings. Duration of antimicrobial therapy for pneumonia varies by patient and infection type. For adult outpatients with CAP, azithromycin is approved for a 5-day course, while other therapies typically last 7 to 10 days. Hospitalized patients may require longer treatment, especially if blood cultures are positive. For HCAP, HAP, or VAP, therapy can range from 10 to 21 days, depending on severity and response. Most patients with CAP should show improvement within 24 to 72 hours of starting therapy. However, those with underlying lung diseases like asthma or COPD may respond more slowly. If a patient is not improving, clinicians must consider comorbid conditions, alternative infectious or non-infectious causes, and the possibility of drug-resistant pathogens. Pneumonia patients do not respond to therapy. Non-infectious causes must be considered. These include pulmonary embolism, heart failure, cancer, intrapulmonary hemorrhage, and inflammatory lung diseases. For VAP, HAP, and HCAP, similar outcome parameters apply, and non-infectious explanations like atelectasis, ARDS, or empyema should be evaluated. Bronchitis and bronchiolitis are inflammatory conditions affecting the tracheobronchial tree. Bronchitis involves the larger airways and can be acute or chronic, while bronchiolitis affects the smaller airways and is primarily a disease of infancy. The inflammatory process in bronchitis does not extend to the alveoli, distinguishing it from pneumonia. Acute bronchitis most commonly occurs during the winter months and is often triggered by respiratory viruses. Cold, damp climates and exposure to irritants like air pollution or cigarette smoke can precipitate attacks. The most common infectious agents are rhinovirus, coronavirus, influenza virus, and adenovirus. In children, parainfluenza viruses and mycoplasma pneumoniae are also frequent causes. Besides common viruses, Chlamydophila pneumoniae and Bordetella pertussis, whooping cough, can also cause acute bronchitis. While primary bacterial infection is rare, secondary bacterial infection may occur, especially in vulnerable populations. Understanding the range of potential pathogens helps guide appropriate management. Acute bronchitis is usually self-limiting and rarely fatal. Infection leads to hyperemic and edematous mucous membranes in the trachea and bronchi, with increased bronchial secretions. The destruction of respiratory epithelium can impair mucociliary function, and thick, tenacious secretions further reduce the airway's ability to clear pathogens. Hallmark symptom of acute bronchitis is a persistent cough, which may start abruptly or gradually and can last for several weeks. Initially, the cough is often non-productive, but may progress to produce mucopurulent sputum. Other symptoms like dyspnea, cyanosis, or airway obstruction are rare unless there is underlying lung disease. Fever is not always present in acute bronchitis, and when it does occur, it rarely exceeds 39 degrees C, 102, 2 degrees F. Fever is more common with certain viral infections like adenovirus, influenza, and mycoplasma pneumoniae. Severe complications are uncommon unless the patient has pre-existing pulmonary disease. The primary goal in treating acute bronchitis is to provide comfort and support, as the condition is usually self-limiting. In severe cases, treatment may address dehydration and respiratory compromise. Most patients recover with symptomatic care, without the need for antibiotics. Supportive care for acute bronchitis includes reassurance, antipyretics for fever, and bed rest for comfort. Patients should be encouraged to drink fluids to prevent dehydration and help thin respiratory secretions. Mist therapy, such as using a vaporizer, may also help loosen secretions and ease symptoms. Mild analgesics and antipyretics, such as acetaminophen or ibuprofen, are helpful in relieving lethargy, malaise, and fever. Aspirin should be avoided in children due to the risk of Ray's syndrome. Caution is advised with ibuprofen in young children, the elderly, and those with poor renal function. Routine use of antibiotics for acute bronchitis is discouraged due to limited benefit. However, in patients with persistent fever or symptoms beyond 4 to 6 days, or those who are elderly or immunocompromised, a concurrent bacterial infection should be considered. In such cases, antibiotics may be directed toward likely respiratory pathogens. Chronic bronchitis is defined by a chronic cough productive of sputum lasting more than 3 consecutive months per year for at least 2 years, without other causes like bronchiectasis or tuberculosis. This condition is a result of multiple factors, including smoking, occupational exposures, and genetic predispositions. Most prominent causes of chronic bronchitis include cigarette smoking, exposure to occupational dusts and fumes, environmental pollution, and host factors like genetics and infections. Reducing exposure to these irritants is essential for managing and preventing chronic bronchitis. In chronic bronchitis, the bronchial wall thickens and the number of mucus-secreting goblet cells increases. This leads to more mucus in the airways, impairing lung defenses and causing frequent mucus plugging. Additional changes include squamous cell metaplasia, edema, and chronic inflammation, all contributing to persistent symptoms. Hallmark of chronic bronchitis is a persistent cough, often producing large amounts of sputum, especially in the morning. The sputum can vary in color and may be accompanied by a bad taste in the mouth. Patients may expectorate up to 100 ml more sputum daily than normal, leading to discomfort and social challenges. The main goals in treating chronic bronchitis are to reduce the severity of chronic symptoms and prevent acute exacerbations, aiming for longer infection-free intervals. Achieving these goals improves quality of life and reduces the risk of complications. Key step in managing chronic bronchitis is minimizing exposure to bronchial irritants. This includes smoking cessation and avoiding workplace pollutants. Taking a thorough occupational and environmental history helps identify and address sources of exposure, supporting better long-term outcomes. Short-acting beta-2 agonist bronchodilators, like albuterol, are used to relieve airflow limitation in chronic bronchitis. Long-acting beta agonists, such as salmeterol or formoterol, may be more effective and convenient for responsive patients. Inhaled medications are preferred over systemic forms to minimize side effects and improve compliance. Use of antibiotics for chronic bronchitis has been controversial, but is increasingly accepted, especially for acute respiratory exacerbations. Oral antibiotics are commonly prescribed when bacterial infection is suspected, helping to reduce symptom severity and prevent complications. Bronchiolitis is an acute viral infection of the lower respiratory tract, primarily affecting infants and young children. It is most common during the winter and early spring, and is a leading cause of hospital admission in the first year of life. Boys are more frequently affected than girls. Respiratory syncytial virus, RSV, is the most common cause of bronchiolitis, responsible for up to 75% of cases. During epidemics, RSV may account for up to 90% of cases. Other viruses, such as parainfluenza, adenovirus, and influenza, can also cause bronchiolitis. Bacterial infections are rare and usually secondary. Bronchiolitis presents with symptoms such as cough, wheezing, difficulty breathing, and sometimes fever. Infants may have trouble feeding and show signs of respiratory distress. The severity can range from mild to severe, with some children requiring hospitalization for supportive care. Most cases of bronchiolitis are self-limiting and can be managed at home with reassurance, antipyretics, and adequate fluid intake. However, infants with respiratory failure or dehydration may require hospitalization for oxygen therapy and intravenous fluids. Underlying cardiac or pulmonary diseases can increase the risk of severe illness. In severe cases of bronchiolitis, the mainstays of therapy are oxygen and intravenous fluids. Aerosolized bronchodilators may be considered for children with bronchospasm, and antiviral therapy with ribavirin may be used in select cases, particularly in infants with underlying health conditions. Most children recover fully with supportive care.